No. Oh yeah. Patients need this. Patient need this. God gave us the sunflowers. Give me a pin. Oh, here.
So good morning, everybody. Welcome back to the Sarcoma Exchange for 2019, our second annual exchange. I'm Alyssa O'Driscoll. I'm the Executive Director of the Sarcoma Alliance. We're really excited to see you all here, and I'm loving all the yellow. This is great. You all got the memo, so hopefully you're getting really acquainted with each other, and you made some friends last night at the reception if you attended, and getting to know each other here this morning. You know, Eve and I had a really great experience yesterday at the reception. I met someone who grew up only a few miles from me in Kentucky, so that's what this is all about. I mean, what kind of connection could you make like that outside of this room? So Pam, is Pam in here? Oh, she went to the restroom. Yeah, that's great. So that's not only what this is all about, but also just taking away a lot of information throughout the weekend. We have a really great program lined up for you. This is our second Sarcoma Exchange. Yay, we're back! Originally, we had 96% of our constituency say that they would love to have an in-person meeting. So I know a lot of you are active online, and I know that that's a really great vehicle for relationship building, but there's nothing that can replace the face-to-face meeting and understanding from each other the journey and the experience of living with sarcoma or being a caregiver or survivor. We had a wonderful response for our first Sarcoma Exchange. Thank you so much for filling out those surveys last year if you attended. We really take the feedback to heart. So you have surveys in your bag, so make sure to fill out those evaluations before you leave. And we'll take those to heart. We also incorporate that into our next Sarcoma Exchange. So we intend for this to be an annual program. And then, of course, if you have comments, questions, you can always feel free to reach out to me. I'm the executive director. My email's up here, aodriscoll@sarcomaalliance.org. Yes, Susie's already provided some feedback last night, so thank you, Susie. And I also have business cards out at the Sarcoma Alliance table, too. So just a little bit about who we are. We were founded more than 20 years ago by Suzanne Leiber, and we're really the only nationwide nonprofit organization with the sole mission to provide guidance, education, and support to everyone affected by sarcoma. We are pan-sarcoma, we are agnostic, and we don't really raise funds for research at all. We leave that to other groups. That is really important work that may help people in the future, and instead our funds are raised for people who are affected by sarcoma right now. We have a really active volunteer base. Thank you, over here on the left, and all of our board of directors. We're always recruiting for new volunteers, so feel free to reach out to me as well if you're interested in helping out. And then I just wanted to speak a little bit about some of our programming. I'll get into much more detail during our nonprofit panel of resources available for folks who are affected by sarcoma, but we have our web-based information, of course, lots of details, everything from financial assistance, other affiliated organizations that help out, and it's a very robust resource guide for you. And then we have our support groups both online, and then we have a list of support groups in your area, whether it's in Miami or others around the country. And then we also have our peer-to-peer group. If you're interested in more of a private connection and don't want everything on Facebook, you can sign up for our peer-to-peer program as well. And one of our signature programs that most people know us for is our financial assistance program for second opinions from sarcoma specialists. Specialists like Dr. D'Amato and some of our speakers that you will hear from later today. Ocean of Hope is our fundraising series of athletic events. Primarily takes place in California. You can see here it's a really moving fundraising event, and so far they've raised more than $850,000 to help support what we're doing here today, as well as all of our programming. And really why the Sarcoma Exchange, and I have to give kudos to Alyssa, who wasn't able to make it here today because of a work-related event. But Allison served on the board of directors and was executive director before me. She really saw a need for information exchange and conceptualized this event and the programming. We only have 1% of cancers that are sarcomas. 16,000 people are diagnosed in the US each year. And there's a real feeling of isolation with a rare diagnosis, which I'm sure everyone in this room can relate to. And many doctors are unfamiliar with sarcoma. Oncologists may see Dr. D'Amato maybe one to three per year, something like that. You'll speak more to that later on. And then we're really the end of the line for the referrals for other nonprofit organizations. So we have a full agenda for this weekend. They were in your tote bags, so take them out and we'll go through them together. This morning we have Sarcoma 101 by Dr. Gina D'Amato, and then that will be followed by Sarcoma Pathology by Dr. Andrew Rosenberg. Then we'll have a presentation about targeted treatments by Dr. Jonathan Trent. And then at the group lunch, you'll have opportunities to sit with the physicians, sit with others from your sarcoma subtype, and then you'll hear from representatives of nonprofits, including our sister organization, Sarcoma Foundation of America, Gilda's Club and Cancer Support Community, which is another partner of ours, and then of course the Sarcoma Alliance meeting. And then this afternoon, we're going to have breakout sessions where you can feel free to ask or discuss anything you feel. You need to go to the breakout group that best describes you. So we have breakout groups divided into 3 sessions. We have patients in treatment, which will be in this room. And then we have caregivers, that includes family and friends, and that's on the 3rd floor in the Tampa or Orlando group meeting space. And then survivors, people who have had sarcoma but are not currently in treatment. So that's also on the 3rd floor as well. And then we'll have dinner back in this room at 6 p.m. with great entertainment by Nicolita Johnson, the wonderful string quartet we heard yesterday, which was lovely. And then afterwards, for those who are feeling brave, karaoke, led by Suzanne Schwartz. Tomorrow, for Sunday, we'll hear from Dr. Robert Mackey on clinical trials, and then Dr. Bob Benjamin on chemotherapy. And then after the break tomorrow, we'll have radiology by Dr. Venkat, surgery, Dr. Goel, radiation oncology by Dr. Icelli. And then after lunch tomorrow, we'll hear how to deal with some of the side effects of cancer, including palliative care by Dr. Suarez, nutrition by Dr. D'Amato again, and then physical therapy, exercise and fatigue by Anime Elise. And of course, we couldn't be having this wonderful patient conference without our sponsors, including Lilly, Eisai, Epizyme, Novartis, Genentech, and Daiichi Sankyo, and of course, because of all of you in the audience as well. So thank you. So welcome, welcome, welcome. Now that you know a little bit about the Alliance and the Exchange, we want to start to get to know everybody a little bit better, right? So if you haven't already, please introduce yourselves around the table.
Hi.
She's my phone. Sponge is my phone. She helps me enormously.
Everything.
So the next thing I wanted to see if who traveled the farthest to be here today. So Susie's pointing at me. I'm from Utah.
There's someone from Thailand. Ask and see. Ask if they're
So go ahead and raise your hand. Everybody raise their hands up. And then if you are from Miami, put your hands down. Everybody from Florida, put your hand down. Southeast, put your hand down. Northeast, Central, Intermountain West, California, Pacific Northwest. Anyone outside of the country? You're outside of the country?
Yeah, but they're Midwest.
Midwest. Okay. Oh, I'm sorry. I thought that was Central. Is there anyone from the Pacific Northwest? Okay. You can come grab a prize. We have a few items. Yay! Thank you for being here. That's a long trip. I have a selection of goodies over here. Are you from Oregon? Washington?
Seattle.
Seattle. All right.
Yes.
Coast to coast.
Oh, good. Yeah.
Good choice.
Somebody take a picture of that. Looks good. And then I also want to see survivorship. So if you're a survivor for at least 3 years, please put your hands up. Great. Awesome. 5 years. Awesome. 10.
She's not putting her hand up.
Survivors at least 15 years.
At least.
Wow.
Yeah.
20. 20.
Keep putting it up.
25. Susie, yeah. 30. 35. 40. 45. Yeah. 48. 49. We're giving her exercise. Yeah, that's great. Susie, you can pick up our prize too. Congratulations.
I waited 48 years to meet y'all.
Oh.
Y'all are my favorite.
Susie honestly has one of the best hearts I've ever met of anybody.
Because of y'all.
You gonna grab the earrings or the necklace? Yeah. Thank you, Susie.
Wow.
You're an inspiration. Okay, so next up we have Dr. D'Amato. She's going to talk to us about Sarcoma Cancer 101 and give us a vocabulary lesson. She's an amazing person. An inspiration to everybody in this room. And if you haven't met her and spent some time with her, I definitely encourage you to do so. She's a wonderful person. I don't think she sleeps. So she's going to talk to us a little bit today. She's with University of Miami and based here. So we're excited to have her.
Okay. Well, thank you guys so much for coming. This is really special. As Alyssa said, this is our second annual. Last time, who was here for the first annual? All right, good. So we got some repeat. So you guys remember last year it was in Atlanta because I was working in Atlanta, but just how patients shop around for doctors. Doctors sometimes shop around for institutions. And so I've been in several institutions and little Goldilocks syndrome. And I'm really excited to be back in Miami where I belong, wearing yellow, with my mentor, Dr. Trent, who's a week later. He's been my mentor for 16 years, and there have been a lot of inspirational mentors that you'll meet tomorrow, Dr. Mackey and Dr. Benjamin. But Dr. Trent has been at University of Miami for 7 years and has been recruiting me, and finally here, so very happy. Because we have, last year I did both a Cancer 101 and Sarcoma 101, but because we have the esteemed Dr. Rosenberg, I'm going to focus more on cancer, and then he's going to talk a little bit more about sarcoma. So we'll go ahead and start just the cancer vocabulary lesson. So number one, what is cancer? Okay, essentially cancer is uncontrolled growth of abnormal cells in your body. Okay, they're called cancerous cells, also called malignant cells. They grow out of normal cells in your body, and normal cells grow when they need to be made. So for example, you get a cut on your arm and you need to make more skin cells. Well, the genes that are responsible for turning cell growth on, they get turned on, and then more cells are being made. They grow and divide, and then they say, okay, I need 50 cells, okay? You need 50 new skin cells, and then it stops. But with cancer, the cells just keep growing and dividing. So it comes out of normal cells that become abnormal and grow out of control. And also, sometimes your cells get damaged, and these damaged cells are supposed to die, but the cancer cells forget how to die, okay? And cancer can start out anywhere in your body, from any cell in your body, and you have all different kinds of cells in your bodies. So what's oncology? Oncology is the study of cancer. So an oncologist is someone who treats cancer patients. There's all different kinds of oncologists. So, and we all train differently. So we all go to med school, and then after that we have to specialize in different specialties: internal medicine specialty, pediatrics, surgery, radiology. And then if we want to specialize further and study cancer, then we do a fellowship in that specific specialty. So a medical oncologist does internal medicine, and then they do medical oncology. Now, most medical oncology, they do a combined fellowship where it's a hematology, blood, and oncologist. So you'll hear the terms hem-onc. They have a combined residency program, fellowship program. Most of us do that, but then if we are a specialist in one particular cancer, then we either are a medical oncologist or a hematologist. So most physicians in academia, they either have to pick, are they a med-onc or are they a hematologist? But a lot of the private practice physicians, they kind of say that they're a hem-onc because they treat blood cancers like sickle cell or clotting disorders, and they also treat cancers. Pediatric oncologists, they do pediatrics residency, and then they do fellowship in pediatrics, so they treat cancer patients 18 and below. But some pediatric oncologists will treat young adults if the cancer that's affecting the young adult usually occurs in children. Surgical oncologists, these are the people that wake up really early in the morning and they stand most of the day, which I cannot do, and that's why I'm not a surgical oncologist, one of the many reasons. But you also have to be very coordinated. So they do the whole surgery residency, and they do surgeries, and we're going to be hearing from a surgical oncologist tomorrow, Dr. Goel. Then you have gynecologist oncologists. So they're gynecologists, but then do a fellowship in gynecology oncology, and they treat cancers of the GYN origin. So that's uterine cancers, ovarian cancer, cervical cancer. Okay, they do not treat prostate cancer, not yet anyways. They will be soon with all of it. Okay, and then we have orthopedic oncologists, and they are orthopedic surgeons, and they treat bones. So they treat bone cancers, they do surgeries, and then they also do surgeries on cancer patients that have the cancer spread to the bone, and they need to help them out as well. Okay, and then other people that I forgot to add on the list because I turned in my slides really late last night, but other people that are involved in the care of cancer patients but don't have oncologists by their name is the pathologist. We'll hear from esteemed pathologist Dr. Rosenberg, and there's a surgical pathologist or anatomic pathologist, clinical pathologist, and they are the doctors that make the diagnosis of the cancer. So they diagnose the cancer. And then we have radiologists that are involved, they read the films and they help us decide. We have interventional radiologists. It's a specialty of radiology, which you'll hear from Dr. Venkat. And then you have, I forgot to say about radiation, and then you also have the radiation oncologist. That's a specialty. They do 5 years, just special residency, and they don't have to work on nights and weekends, or we won't talk about that here. Okay, which I should. Okay. Sorry, I keep forgetting that I stole this slide from the internet, and I keep needing to change it and I never do. Anyways, so healthy cells represent the smallest functional unit of our existence, okay? And they contain two parts. They contain the cytoplasm, that's the worker bee, and then you have the nucleus that holds the genes, okay? And your genes are on the DNA, and they're basically genetic material that's coded, and everyone has different, we all have a set of DNA, a separate set, and that's how we can get it from blood, we can get it from a hair follicle, because we all contain, I contain the same DNA in my hair, in my lungs, in my liver, just not all the genes are turned on. Only the liver genes are turned on in the liver. Only the skin genes are turned on, but the DNA is the same, and that's how we can, get criminals, okay, because we can do DNA sampling. The only two people that would have the same DNA are identical twins, which are really cool, but anyways. Okay, so the genes that are responsible for cell division and control of cancer growth, cell growth, those are the ones that are abnormal, and those are the ones that cause cancer. So Biology 101, okay, who loves biology? Okay, I figured this out. Dr. Trent, you don't love biology? Okay, okay. All right, anyways. So Biology 101. So what happens is that, you have your genes, that all these genes are contained on your chromosomes, and you get 23 chromosomes from your mom and 23 chromosomes from your dad, okay? And you get two pairs, and they both have to work for them to be working properly. And so what happens is when the cell has to be made a new one, it undergoes cell division or mitosis. And all the chromosomes line up perfectly, and the cells are a clone of each other. And then when that becomes abnormal and the cell is not a clone of each other, then the cell doesn't work properly. Okay, so normal cell division, you can see here, 1 makes 2, 2 makes 3. Oh, this one's abnormal, it's supposed to undergo apoptosis or cell death. But with cancer, the cell division, it continues to make these abnormal cells, and they grow out of control, okay? And then on the surface of a cell, you have these little receptors. A normal cell has a normal number of receptors. And what happens is, if you need to make a new cell, a growth factor will bind to this receptor and tell it to grow and divide. But with a cancerous cell, they have all these receptors, and they keep getting turned on. So a neoplasm or a mass is basically a clump of these abnormal cells, okay? And if it's a cancerous, it has the ability to get into the bloodstream and go to other places, okay? Here's an example of a mass in the brain, okay? So tumors, what are tumors? You have benign tumors and malignant tumors. Benign tumors are just a collection of abnormal cells, but they don't have the ability to go into your bloodstream and spread to other places. But benign means do no harm, so they can cause some damage because they can push on other things and they can cause pain and they can interfere with normal function based on where they are. So some of these benign things need to be removed, and we do have some benign variants of sarcomas called desmoid tumors or fibromatosis that our sarcoma physicians treat, and they're benign, they're not cancer, but they can do some harm, and we actually treat them with some of the similar treatments that we give to sarcoma patients. Malignant tumors are cancer, so same thing, malignant cancer, and they grow fast, and they can grow fast, and some can start out benign and then mutate and turn into malignant and go into the bloodstream. Not all cancers start out from benign tumors. Some start out from benign tumors, like for example, colon cancer. Colon cancer usually starts out from a benign polyp, but then mutates if left untreated or not removed, it can mutate into a normal tissue, a cancer, colon cancer. So that's why everyone has to get their colonoscopies by age 45 now. So because with the colonoscopy, we can remove the polyp so it never turns into cancer. Now sarcomas, we don't know. Some sarcomas can develop from benign tumors, but most of them we think just popped up as cancerous. But still, it's still a question, one of those million-dollar questions that we still don't know. Okay. So cancer, again, has the ability to spread to other organs. So for example, your normal muscle cell does not get into the bloodstream and show up in the lungs. We have systems in place that say, wait a second, you're not allowed to go here. But somehow cancer cells are able to get there without being stopped, okay? So there's two ways sarcoma cancers spread, mostly through the bloodstream, okay, and then or through the lymph system, which runs along the same path as your blood stream. Okay, so sarcomas, most sarcomas spread through the bloodstream. We don't really check for lymph nodes, but there are certain sarcomas that can spread through the lymph system, such as synovial sarcoma, epithelioid sarcoma. So sometimes we do have to do extra testing with the lymph system. Okay, but so why do some sarcomas that start out in the leg go to the lungs? Okay, because the artery, the heart pumps the blood, the red blood, the oxygenated blood to the organs and the tissues, and then the tissues uptake the oxygen, and then the veins bring it back through the lungs to oxygenate it into the heart. So if you have a tumor here, it takes up the oxygen, then it goes up through the vein to the lungs. Okay, that's how it, now if you have a tumor in the pelvis area, it could go to the liver or it could go to the lungs, so it goes along that thing. So that's why, and certain cancers spread to certain areas, certain cancers never spread to certain areas. Okay, so when we treat cancers, we kind of lump them into different groups. We have what's called solid tumors, the liquid tumors, the hematologic malignancies, or we can group them by system. Okay, so you have solid tumors, which we can see on scans, and those are called either carcinomas, sarcomas, melanoma, so carcinomas, which I'll explain, sarcomas, melanoma, and CNS. Okay, so the solid tumors, so this is back to embryology, which is like one of the first courses that we take in med school, and I have a little post-traumatic stress disorder from it because I was paranoid I was gonna, not pass. But anyways, and you can look at my pregnant nurse practitioner over here and picture it. I don't want to call you out, but anyway. So how it gets this big is when it starts out just as a little zygote, and then over time, the baby develops into 3 different layers. You have the endoderm, the inside layer, the mesoderm, the middle layer, and the ectoderm. And the endoderm, the middle layer, is what makes epithelial cells, which eventually form your organs, okay? So your organs are mostly consistent of these epithelial cells that make up the majority of the structure. Now you have connective tissue cells that kind of support everything, but the organs are made of these epithelial cells. So if the epithelial cells turn into cancer, epithelial endothelial cells turn into cancer, it's called a carcinoma. So those are the most common types of solid tumors or carcinomas: lung carcinoma, colon carcinoma, breast carcinoma. Then you have the middle layer here, the mesoderm, that makes your connective tissue and makes your bone marrow and blood cells. So that's the mesoderm, which then makes your mesenchymal cells, which are your connective tissue. And then you have the ectoderm that makes the skin. So it's very interesting that carcinomas occur mostly in adults. Okay, you don't really hear of a child getting breast cancer or colon cancer. And sarcomas, which are the middle layer, make up, children can get it, and young adults, and all ages, and older adults, okay? The hematologic malignancies, the leukemias, the lymphomas, the multiple myelomas, the MDS, which is like a pre-cancer, and the myeloproliferative, which is like also a cancer, those are all from the middle layer. And children can get leukemias and lymphomas. So we actually, even though sarcomas are a solid tumor, we actually have a lot in common with leukemias and lymphomas. And when we send out our tumor specimens for special molecular testing, we actually check the heme box because we share similar abnormal genes than the solid tumors. Okay, and someone will tell me where I am on time. Okay, anyways, you'll have fun. Right? Okay, so then the cancers are named from the cell of origin. So like a chondrosarcoma, chondrocartilage, adenogland. So you'll hear like adenocarcinoma or adeno. So then adeno is a gland. Okay, so that's mostly for carcinomas. Lipo is fat. Bone marrow is myelo. So when you hear myelosuppression, the bone marrow, osteobone. Okay, so again, carcinoma, skin or tissues that cover the internal organs, epithelial cells, sarcoma, bone, cartilage, fat, muscles, blood vessels. Melanoma are the melanocytes, not the cells in your skin that are responsible for pigment. Okay, CNS cancers start out in the brain or spinal cord. Leukemia, immature white blood cells of the bone marrow. Lymphoma, the mature blood cells that go in the lymph, that start out in the lymph nodes. Okay, and then multiple myeloma are these mature white blood cells that are supposed to make antibodies to fight infections. Instead, they develop abnormal cells and cause problems. And then some other things that you don't have to worry about. Okay, so that's for my Leukemia Lymphoma Society talk, so don't worry about that. Okay, anyways, and then the incidences, this is last year's, but it's pretty up to date. So in the United States, 1.7 million Americans will be diagnosed with cancer every year. Pretty much equal distribution between men and women, maybe a slightly more in women. And then you see here breast cancer, about 268,000. So it's one of the most common cancers. And you can see here, even men can get breast cancer, okay? And here we are in the sarcomas. Here we have the soft tissue sarcomas, about 13,000, and bone and cartilage. So we have a total of about 16,000. Now, I kind of disagree with these numbers because my clinic is totally packed. I've been treating sarcoma patients for 15 years, and I always have a packed clinic, and all the doctors that we talk to, they're all overworked. So I really think it's higher than that, But anyways, now this is the incidence. That's the number of people that are diagnosed with the cancer every year. That doesn't mean the prevalence, the number of people living with the cancer, okay? If they've had cancer before or they're living with it, that's the prevalence. So they don't really report the prevalence. So I think the prevalence is much, much higher than what we think. It's usually 3 times the incidence, but I think it's much higher because we have a lot of patients surviving, okay? And you can see here, actually more men get it than women in the soft tissue, more men get it than women, which is surprising because I know a lot of you are on the internet and maybe you thought that maybe women have it more than men, but that's just because women, we like to talk and we're more, you know, we're more likely to go on the internet and go on these support groups, you know, and if you're a man, you usually are probably dragged here from your wife, okay, but let's be honest, or your sister or whatever, okay, so, but it is true that it is more common than that, okay. All right, so how do we diagnose it? With a biopsy. That's the only way we can diagnose cancer, the majority of cancers, maybe 1 or 2 leukemia lymphomas that you can maybe diagnose with a, it's pretty much no cancer. You have to have a biopsy, okay? So it's when we remove a sample of an area that may be cancer. So we can use what's called an FNA, fine needle aspiration, but that's when we only look at 1 cell. So if you had, say, a breast cancer, we know, okay, it started out in the breast, most likely it's going to be breast cancer. We can just get a little piece and the pathologist can make the diagnosis. But with sarcomas, and Dr. Rosenberg will talk to you, we need to get a core needle biopsy because he has to look enough under the microscope to make the diagnosis. So we do core needles. Sometimes we can't get enough tissue just by looking at the core, and we actually have to do an excisional, means we remove the whole thing, or incisional, the patient has to be opened up and taken to the operating room to remove it. Now sometimes it can be diagnosed with endoscopy. If you ever see oscopy, that means we use a camera. Okay, so oscopy, otomy means we open you up. Ostomy, oscopy, means a camera. Okay, so either a pharyngoscopy where you look at the head and neck, doctors do it, the colonoscopy, cystoscopy, bladder, bronchoscopy, lungs, okay? Or endoscopic ultrasound for GISTs. That is a special technique where they can get into the wall of the esophagus. So mediastinoscopy, sometimes we have to take a camera and look in the mediastinum, in your chest, and the thorax or chest area for lungs, thoracoscopy or laparoscopy. Laparo means abdomen, okay? And then open surgical exploration otomies, okay? Lung or abdomen. So other cancer terms, which is always confusing to people, and it's still confusing to me, and that's why I didn't put it in writing. But anyways, okay, and there's no defined terms, okay? So basically, a tumor is a collection of, well, we think it's cancer or it could be benign. Okay, a nodule usually describes something very small, usually less than 1 centimeter or maybe less than 2 centimeters. We use centimeters when we measure things, even though, you know, we use inches in America, but in medicine we use centimeters. I don't know if you guys remember back in the 80s when there was a whole movement to move to the metric system. Well, apparently it didn't take on. It would have been nice because then when I talk to patients, they would know what a centimeter is. But anyways, but so centimeters. So usually a nodule is a collection. We don't know for sure it's cancer, you know, until you get the biopsy, but it's a presumption. But it usually means it's something really small, less than a centimeter. When it's a lesion, that's the same thing. Some people call it a lesion. Some people call it a nodule. We don't know. Maybe it's from the Midwest or South. We don't know. Okay? A mass usually means a collection, a tumor. It usually means bigger. Okay? But sometimes they'll describe a mass as 3 centimeters, or they would call it a nodule 3 centimeters. We don't really know. There's no defined terms, but that's what that means. Usually mass is something bigger. And a lump is something that we can feel that can be a mass, could be not. So a lump is something that you feel, And the mass, the lesion, the nodule is something that we can see on the radiology imaging. Staging is the stage of the cancer has to do with where the cancer is located, okay? And every cancer has a different staging system based on certain criteria. For sarcomas, staging has to do with the size of the tumor, the grade of the tumor, which is how fast it's growing under the microscope, and whether it's spread to other organs. Okay, so that's the stage, okay, which is different than the grading that Dr. Rosenberg will discuss, okay? And then, so that's the difference. Grading has to do with what it looks like under the microscope, and the stage is based on the kind of sarcoma that is, where it's located, and the size, and if it's spread, okay? And then types of treatment, we have the localized, meaning we're just attacking one area, okay? So if you have a surgery, you get the one area. Radiation will go to the one area that's called localized. And then there's interventional radiology techniques like ablation that we'll be talking about tomorrow that's targeting one area. Then we have systemic, that means something that's getting in your bloodstream that kills everything, and that's medication, okay? So we have medication, chemotherapy, which is medicine that kills cells that are growing and dividing, usually is given through the vein, but we do have some oral chemotherapies. We have what we call targeted, and you'll talk, Dr. Benjamin, who discovered chemotherapy, he didn't discover chemo, but he discovered the use of it in sarcomas. We'll be talking tomorrow about chemotherapy. Targeted therapy is when we try to prevent the cell from growing and dividing. We try to stop that signal. Remember, we say this cancer cells get the signals to grow and divide. Chemo kills it when it's growing and dividing. Targeted therapy tries to stop the signal so that it won't grow and divide. It doesn't know what to do, and it dies, because that's the only thing that the cancer cell knows how to do, grow and divide. It doesn't have any other function, okay? And then immunotherapy, when we use our immune system to kill the cancer, okay? And then other terms, other cancer terms, cure. Cure refers to if you've had a treatment that has the ability to eliminate the cancer totally from your body and it never come back, okay? There's been some variations on the term, but by the guidelines that we use in medicine, if you had a curable cancer and you received treatment and it hasn't come back in 5 years, you're considered cured, okay? If you have a curable cancer and it's within 5 years, but you can't see the cancer, you have no evidence of cancer, it's considered remission, okay? No evidence of disease means that your cancer wasn't curable, meaning that it's in multiple areas, but we can't see the disease. You had a treatment and currently we don't think it's there, okay? Then we consider that no evidence of disease. So a lot of times you'll see your scan will say no evidence of disease. Now, did you have a curable cancer? Is that remission? You know, it's all semantics, but that's kind of the true definitions. Metastatic means that it has spread from one area to the other, okay? And then treatable means that, so you have curable and treatable. Curable means there's something that we can give you that can eliminate the cancer totally from your body and it never come back. Sometimes we can't do that, but we can still treat it. We can still get it under control, because remember, you can live with cancer in your body as long as it doesn't affect the function of your major organs. So you need your major organs to live. You need your heart, you need your lungs, you need your liver, you need your kidneys, and well, my joke that you probably, most of you have heard is the brain, I don't know if you need the brain. So that's and it's rare that sarcoma spread to the brain, so we don't have to worry about that one. And most people, you know, are we using our brain most of the time? So, but anyways, and you only need one kidney to live, and you only need less than one lung, and you only need 20% of your liver. So we can get it under control until it takes over a certain organ function. Okay, so that's what we call treatable. Okay, and then we call stage 4, which I'm supposed to put a little red line on. I don't really like to use the term stage 4. Everyone's like, what stage am I? I'm like, well, technically you're stage 4, but stage 4 just has a really bad connotation. Stage 4 just means that it's spread to other areas. okay? It means that we can't get rid of the cancer totally from your body, but we can under control treatment to protect your organs, okay? So you can have cancer, you can have cancer that spread from one area and one little small thing in your lung, or your body can be riddled with cancer in your stage 4. So that's why I don't really like to use the term, but that's what it is, okay? We have a complete response. If we gave you something that cancer totally went away, big lump, gone, complete response. If it got smaller by 30%, that's a partial response. If it could have gotten a little bit smaller, but maybe not that much smaller, but it didn't grow, stable disease, okay? So that's what we like. If we're cancer, we just don't want to grow. Okay, so we're happy with stable disease. Everyone wants a complete response, which is important to have your hopes that you can maybe get a complete response, but doctors are happy with stable disease, okay? And then we have progressive disease. That's when the cancer is growing, when the treatment that you're currently on is not working and we need to switch it up. We call that progressive disease, okay? And other terms, we have hereditary and genetic. Most cancers, the cause is unknown, or it's not necessarily hereditary. Hereditary means that you got cancer is caused by a mutation in genes. Sometimes we know what the gene mutation is, sometimes we don't. Sometimes we know what causes the mutation, most of the time we don't. So genetic just refers to that we may know about the gene mutation. Hereditary means that that gene mutation was passed on to you from your parents, and that you develop cancer, and that gene then can be passed on to your children. Okay, it's rare in sarcoma, but it's possible. But that's the difference between hereditary and genetic. And then indolent means slow growing, okay? And aggressive usually means fast growing, but it doesn't necessarily. Sometimes aggressive means where it's located. If it's behaving like if it's causing pain, we call that aggressive. If the treatment has a lot of side effects, we call that aggressive. So it kind of has, multiple connotations, okay? And then the most important term that we have is hope. Okay, that's the most important term we have. So everyone has to have hope, and hopefully this, you guys being here will give everybody hope. Sarcoma Alliance, has been close to my heart, and feel that it's given me hope. And the important thing is that you feel like you're not alone. And so hopefully after this weekend, you'll feel like you're not alone and you'll have a lot of hope. Okay? You guys have, and thank you guys for coming. I'm sure I have my contact information somewhere. I think later we'll have maybe a panel for question, or we're gonna. Oh, I can take 10 minutes for questions. Oh, last year we were so behind, but Okay, anyone have any questions? Yes. And then Dr. Rosenberg again will talk specifically about sarcoma. We kind of divided up the, yes. So that's why I don't like to use stage, because it's so confusing. But anyways, so if it has spread from one area to the other, then it is considered stage 4. But if it's been removed and you can't see it anymore, then you just get deemed as no evidence of disease. Okay.
Do you happen to know if there's any associations with dioxin, like whether hereditary or genetic?
Mm-hmm.
Like right now, I'm looking at that. My father had a carotid sarcoma and chondrosarcoma. And he was exposed to dioxin, actually spraying it in the brain. He had 4 different cancers. And I kept telling him, like, I think I'm high risk, And then passed. And then, I find out. And then the first thing my AO doctor asked me was, tell me, have you ever been exposed to dioxin? I hadn't had the other two. And my only connection was a dioxin connection, and I was like, wow.
So most sarcomas, the cause is unknown. There are some associations with previous radiation for other cancers, so we call that a radiation-associated sarcoma that can occur about anywhere from 3 to 23 years after you've received radiation from another cancer. There are some hereditary syndromes that like, for example, a mutation in the P53 gene that, and I think Dr. Rosenberg has some slides on this, but it's the P53 gene that patients, their families have multiple cancers in the family. So the only way we can know for sure if you have a hereditary cancer is that if there's a lot of cancers in the family and you have a sarcoma, you can go to the genetic counselor and they can do special gene mutation analysis and see if you do have a hereditary cancer gene. And if you do, then you can be closely monitored, because based on what the gene mutation is, you may be susceptible to other cancers, and then your siblings and your children may be susceptible to other cancers. Now there are certain, so usually I'll send someone to the genetic counselor if they have a lot of cancers in the family. Most of the time, it winds up, they do the testing and they don't find it, but sometimes we do, and then we can be closely monitoring, and then siblings and children can be tested and they can get closely monitored. Now the certain toxins have been associated, so for example, tamoxifen that we give for breast cancer, that can be associated with uterine sarcoma, and then we have dioxin, and we have pesticides, okay? So a lot is unknown about that. I know that we have the lawsuit. I don't know if you guys heard about the lawsuit with the Roundup and lymphoma. Now lymphomas are more common, so they've been able to really be able to find that association. Pesticides are less common, but I have seen in my practice several patients that owned pesticide companies, and they were always using the pesticides, and they did develop sarcomas. I did also have another patient that her husband had owned a pesticide company, and she got a sarcoma, and her son had a cancer, and we tested and they did not have any gene abnormalities. So it was not hereditary, so we think it was exposure. So it's possible that your father did get the sarcoma and other cancers from it, and then you were probably exposed to it via your father.
Prior to, it happened before I was conceived, and then after.
So it's,
So he did for years.
yeah, so it's hard to say. The only way we would know for sure would be if you went to the genetic counselor, which you can ask your oncologist to do, and then you can be tested for mutation that was hereditary. If it was not hereditary, if they didn't find a hereditary gene, then probably it might have been some exposure that you had. Maybe not. It's just really hard to say. One more question. Okay.
One other thing, okay, once they asked about risk factors, they asked about risk factors, and then I mentioned, well, dioxin, but not through me. I did my research, and then I found out about the dioxin connection in children born with kind of different cranial spinal anomaly. I ended up, my son was born with cranial spinal, but mild, and then another congenital. So, but I found out that research found that they were doing at University of Arizona with dioxin. So anyways, I saw the sarcomas, chondrosarcoma. Anyways, so I'm just wondering, where is it at right now? Every once in a while I'll look and see.
That's the most that I know. I don't know if anybody have heard anything more. That's just the most that I've heard. They really haven't come up with, at least in the most recent conferences that I've been on, they really haven't had a statement about the Roundup. They haven't really updated. So, you know, that's some of the potential research that we can do. We get a patient registry and we can ask certain questions of certain risk factors, because I have all my, kind of theories.
Oh, I just wanted to mention that veterans exposed to Agent Orange
Yes.
are known to have sarcoma, soft tissue sarcoma, and so
Correct.
dioxin is a component of that. And I believe that family members also sometimes are. So if there are any veterans who were during the Vietnam War,
Yeah.
that's something that, and there are programs specifically for them. So.
Yeah, because they can get, like veterans can get funding from the VA, and so yes, Agent Orange, yes, it's definitely proven.
I checked, and during the time that I checked, it's for the actual, the military members that have worked. And then when I found out, inquiries about the dioxin and how much I was exposed, and not that I know, it was just for the service members. There was nothing for the offspring. And then because my son was born, I'm just thinking, hey, he happens to have what's in the research from these mice, and then they did a rat study, and I'm just thinking, what about humans? How many people with humans have something like that? But I don't have access.
Yeah, I think that the issue is we haven't been diligent on collecting all the data, and when we do our questionnaires, our patient intakes, we don't ask questions, we do ask some, and then we have to try to collect that data. So that would be something that's a nice research project, to be able to try to get some sort of because I'll ask patients if they've been exposed, but I don't ask, but what about their parents? So yeah, that's something that I put my resident or fellow on assignment. Okay. All right. Well, next, I'm going to introduce you to the esteemed Dr. Andrew Rosenberg. So the key to a good sarcoma program is the pathologist, because we are clueless without that, because we can't do any kind of treatment without the pathology. And Dr. Rosenberg is famous internationally. He's written many books. He's trained many pathologists over the years, hundreds of pathologists over the years about soft tissue pathology. He's taught them and he's trained them, and there are sarcoma expert pathologists now because of him. And also there's there's pathologists that know, okay, this is a sarcoma, I'm sending to the expert, because of Dr. Rosenberg, who was one of the main reason why Dr. Trent came to Miami, and one of the reasons why I came to Miami. So, esteemed Dr. Rosenberg.
It's a lot of bull. I want to welcome everybody to the conference, and I want to emphasize you're well aware that sarcoma is a complicated disease, and it requires a lot of expertise and participation from certainly the patients, the patient support systems, as well as the physicians. And that I'm a member of the multidisciplinary group that every patient with a sarcoma should have. But I would ask you, do you recognize me? No. Do you know who your pathologist is? Good. Because that's one important aspect of patient education, is to know how your diagnosis was made, how confident everyone is in the accuracy of that diagnosis. And the problem with regards to pathology and sarcoma is that sarcoma is very uncommon, and it's difficult for a pathologist to accrue enough experience to have the expertise to precisely identify what kind of sarcoma, to give important biological information with regards to the prognosis. How is it going to behave? And I always recommend for any patient regarding any diagnosis related to a pathology specimen is get a second opinion from a pathologist with expertise in that area. In this country, in other countries around the world, there are small numbers of pathologists with a lot of expertise within this area of medicine. I also want to encourage everybody, I view this as an informal group, is to take advantage of the opportunity to speak to people who have a lot of experience in treating sarcoma. And you can see what the word sarcoma literally means. It's generally a mass that is fish flesh-like in appearance. And as Dr. D'Amato mentioned, we classify the different cancers within our body based on how they recapitulate the normal tissues that are present. And we classify sarcoma according to many of the different cell types that are present within connective tissue. And what is connective tissue? Those are the tissues in our body that help provide structure, such as tendons, ligaments, some of the fat. And as well, we also include within that classification other cell types such as skeletal muscle that they resemble. And these are what sarcomas can look like. This is a sarcoma in soft tissue, and again, somewhat fish flesh-like in appearance, a little different, but also similar, sarcoma arising in bone. So the two most common locations that sarcoma arise in are within the soft tissues, which are defined anything in between the skin and the underlying bone. And the second, less frequent location is when a sarcoma arises within or on the surface of the bone. Can a sarcoma arise in an organ like the lung or the liver or the gastrointestinal tract? Absolutely yes. But those are much less common than those that develop within the soft tissues or the bone. Dr. D'Amato has given you information, and as you know, sarcomas are very uncommon. These are numbers that are accrued each year. You can see in the United States, there are about roughly 15,000 new cases diagnosed on an annual basis. You do the math, that's about 1 in every 20,000 individuals, and that's very small compared to some of the more common carcinomas that develop in different organs. Sarcomas account for a small percentage of cancers in adults. You can see that that's 1%. Unfortunately, they account for a significantly higher percentage of cancers in children. So some of the young children have the propensity to develop aggressive sarcomas. And the last number, and it's problematic, you can see of 15,000 new cases a year, a significant number of patients each year die of their disease. And when you do the numbers, it's depending on how you look at it, it's either a small or large number die every day. And that's the importance here of why we need to be able to make advances in all aspects of diagnosing and treating sarcomas. So where in the body do sarcomas arise? And again, I'm going to restrict it to largely those that develop in the musculoskeletal system. When we look at bone sarcomas, they usually arise in the big bones of the body and in the more proximal portions towards the pelvis or upper trunk. So proximal femur, proximal tibia, proximal humerus, pelvis. Those are the common locations. Why do they have a propensity to develop in those anatomic sites? We don't know. Sarcomas that originate within soft tissue. The single most common location is here, in the deep soft tissues. And when I use the term deep, it means within the muscles of the thigh, the abdomen, the retroperitoneum, and again, the deep soft tissues within the musculature of the arm, and we don't understand why that those are the most common locations. Sarcomas can arise in all age groups. When we look at just bone sarcoma, you can see that there's a high incidence, or the highest incidence of sarcomas arising in bone in relatively young individuals, 10, 15, 20 years of age. And that frequency drops off, and then in mid-adulthood and a little older, that incidence increases, and that increase in frequency is related to some degree to sarcomas of bone that are caused by other types of therapy, such as if I had breast cancer and I was radiated and I developed a radiation-associated osteosarcoma in my scapula or rib. In contrast, with regards to soft tissue sarcomas, in absolute numbers, the sort of older the age population, the increased incidence up to roughly the 7th decade of life, and then the incidence decreases. So bone sarcoma, most common in younger patients. Soft tissue sarcomas, most common in adults. But there's always exceptions. Sarcomas can present with a variety of different features. Some are obvious large masses that patients sort of may be in a state of denial and don't want to see a doctor until they can no longer put on their pair of pants. Sometimes sarcomas that develop in the abdominal cavity don't cause symptoms for a long period of time until they're very large. There are others that can present deceptively in an innocuous way. Oh, I thought I cut myself and that cut just doesn't seem to heal. And I think, well, maybe it's just an infection or something like that, but it can be a manifestation of a potentially aggressive sarcoma. And this is just an example of a sarcoma arising on the surface of the bone, highlighting this aspect. Usually, by the time a sarcoma is diagnosed, it's not small, it's large. And it's usually 5, 10, 15 centimeters in greatest dimension. By the time the patient sees the doctor, a biopsy is done and a diagnosis is made. There were questions about the etiology of developing sarcoma. Could it be associated with toxins like dioxin? And again, I think there's evidence that certain kinds of agents that cause trauma to tissue, potentially like dioxin, like radiation, have the ability to interfere with the DNA of some of the cells in the body that result in mutations that result in the development of sarcoma. In the past, there were a lot of questions related to trauma. Oh, I fell and I hurt my thigh and it was swollen and it's now 3 months later and the swelling hasn't gone away. And investigative studies show that, oh, I have a sarcoma. In the vast majority of instances, it is felt that trauma does not have a role in the development of the vast majority of sarcomas. And the way we can say that with a fair degree of confidence is that we're able to determine with some degree of accuracy how long it takes to go from one cell to 1 billion cells, and that billion cells forms a mass that big. And so we can say, on average, that may take a year or 2 years, which does not fit in with that window of trauma. You heard that there are some syndromes, some of them inherited, that predispose a patient to to the development of a sarcoma. And for sure, they exist. They are uncommon. But patients with a history of multiple family members having some type of malignancy certainly should raise the question of whether it could be a genetic syndrome. Are my children predisposed to developing a sarcoma? And then lastly, the causes of sarcoma, the development, I feel, is this in every single case. It is an alteration in the genes of some cell in the body. And that cell, based on our current understanding, and that may change over time as new discoveries are made, there are cells in our body that are known as stem cells, cells that have the ability to differentiate into different tissue types that we may need. For instance, if I cut myself, I'm going to need different type of tissues for that wound to heal. And it's the cells located throughout our body that are there to help repair when necessary. And it's the mutations that are occurring in that cell type likely are responsible for the development of a sarcoma. So again, I want to emphasize, it is mutations, changes in the genes within particular cells of our body that are the cause of the sarcoma. And depending on what that mutation does to the offspring cells determines how quickly that sarcoma grows. What does that sarcoma look like under the microscope? How likely is that sarcoma going to spread elsewhere in the body? So a lot of focus now is based on these genetic abnormalities. So I'm going to take a step back. The genes determine the color of the hair of the sarcoma. The genes determine how tall that sarcoma is. The genes determine how aggressive that sarcoma is. And so the classification system of sarcoma is based on the normal tissues that they try to mimic. And that's a biological principle for all malignancies. They're not mimicking some cell type that doesn't exist. They're mimicking a cell that does exist. So if I develop a sarcoma, may mimic fat, and the name for that is a liposarcoma. And if I develop a sarcoma that looks like a skeletal muscle cell, we have a name for that, rhabdomyosarcoma. That is the basis of our classification system for sarcomas. And the overwhelming majority of sarcomas fall into that category. But there are some sarcomas that are so primitive that when we examine them under the microscope, when we do sophisticated genetic analyses, we can't determine what cell type that normal cell type that is mimicking in the body. And we put them in a separate category. And we may devise a term that is descriptive in nature based on what they look like. So sometimes you may hear a term, a round cell sarcoma, a spindle cell sarcoma. That term, again, is describing what the cell looks like, but we don't know the normal cell that it is mimicking. So here are rough numbers. Again, 90% of sarcomas, I can tell you what the normal tissue counterpart is. 8% are so poorly differentiated, still cannot identify what their normal tissue counterpart. And this number is becoming very much smaller now, a very, very small percentage of cases that are just, so unique, it's difficult to be able to categorize them. Now, I'm going to keep things at a relatively simple level, but for you to be able to understand, because the genetics of sarcoma is extremely important. And I just want to give you an overview of what do I mean by the genetic changes that can occur. We can break them down into two major types of genetic abnormalities. And this represents an example of one group of genetic abnormalities of cancer. What we're looking at are chromosomes. Remember, the normal human cells should have 46 chromosomes. Well, there's one group of, and it's a large group of sarcomas that have many complex abnormalities. Maybe that cancer cell has 60 chromosomes, or maybe it only has 30. But there are many complex abnormalities that are present that are related and associated with that sarcoma. What's the problem with that? We are always looking for the genetic abnormality that caused the cancer. How is that genetic abnormality altering the cells to be aggressive? Because if we know that, we can devise a target potentially to shut that pathway down. And then there are a group of cancers that accounts for about, I should say sarcomas, it accounts for roughly 1/3 of the sarcomas that have very simplistic genetic abnormalities that we can identify. And many of these are the focus of intense research because it may be easier to understand the impact that the genetic abnormality has on the cell. So that may open up an opportunity to intervene and shut that pathway down. And those simple genetic abnormalities sometimes can be very specific to a certain kind of sarcoma. And so that allows me to make a very precise and accurate diagnosis if I can identify that genetic abnormality. The upshot, again, is that the genes of the cancer cells are the most important thing. A very successful cancer is growing rapidly. The cells live for a long period of time. The cells are producing factors that result in normal body to increase the number of blood vessels to go to the cancer so they can get more glucose and oxygen, all the things that they need to live. It's those genetic abnormalities that facilitate those malignant cells to infiltrate to the soft tissues, get in blood vessels, spread, and live wherever they go. And that's why we have to understand the genetics to interfere with the advantages that these malignant cells have. For those in the back, it's difficult to see. This is a picture of an orchestra. The genetic mutation of a cancer cell is like the conductor. And every individual member in the orchestra are aspects in the cells that make the cell grow, live, increase blood vessels. It is the mutation like the conductor, altering all of these complex pathways that are present within each cancer cell, which is determining its behavior. And the new forms of therapy that are being developed now that we are optimistic to be developed in the future are like this. We are going to target that genetic abnormality. We are going to target those pathways that have been activated by the mutation, and in that way stop the cancer, the sarcoma from growing, kill the sarcoma cells, and potentially cure the patient. The diagnosis of sarcoma is a complex process. I can't emphasize enough with regards to my experience, it needs to be done, the patient needs to be cared for by a group of physicians who just spend their time treating patients with sarcoma. That is where an individual will likely get the best care. I am a pathologist. I am receiving tissues that the surgeons are removing from you, or the radiologist is removing from you, or some other physician. I am receiving it in a laboratory, and there are various amounts or procedures that I may receive that tissue. The bottom line is I need to get enough to be able to make a diagnosis if it's a first-time biopsy, or if there's a biopsy being done in an anatomic location with a question, is it metastatic or is it recurrent? And then lastly, I am the person who is looking at the sarcoma that was removed from the patient to be able to identify very important aspects. This is a needle biopsy. This is a CT-guided needle biopsy, mass in the thigh. That's the needle. This is the tissue I get. And I can examine it, obviously, under the microscope, even while the patient is still in the office. I can get that tissue, freeze it to minus 20 degrees, cut a section, stain it. I can tell the radiologist, you're in the tumor. I have enough tissue to be able to make a precise diagnosis. Or I can tell the surgeon, I have diagnostic tissue. I can help expedite the care of the patient. So maybe tomorrow that patient can have appropriate staging studies, see a medical oncologist to, again, expedite the care of the patient. One of my important roles in a biopsy is I need to tell the clinical care team the name of the type of sarcoma. So I have to subclassify it, and I do it the best I can. The next important piece of information that I have to do is tell Dr. D'Amato and Dr. Trent how biologically aggressive it is, because that is going to determine the risk of metastatic disease. That is going to determine whether they recommend to the patient, you need systemic therapy or you do not need systemic therapy. And that prognostic information is housed in the term grade. And so grade, again, is translated into how biologically aggressive. And now around the world, there is consistency. We use a 3-tiered system: grade 1, grade 2, grade 3. Grade 1 is not very biologically aggressive. I don't think you need chemotherapy because the risk of developing metastases maybe 2%, maybe 3%, 5%. Then once you get into grade 2 and 3, that risk goes up. And currently, in most institutions that treat sarcoma, grade 2 and grade 3 are viewed as sarcomas that are a significant risk for developing metastatic disease, and they are treated the same. Based on a lot of studies, grade of the tumor is probably one of the most single important prognostic features that the patient has regarding how to anticipate that tumor is going to behave. And this is just a graph to show you this is survival, not based on sarcoma type, but sarcoma grade. Grade 1, the sarcoma survival, and again, this is percent of patients surviving, is much higher than grade 2 and grade 3. This is why you want a pathologist who sees a lot of sarcomas who can grade very accurately. Because the distinction between grade 1 and grade 2 currently has a lot of implications regarding what kind of therapy is going to be recommended to the patient. These are two histological images, kinds I see many times every day. But for you to see, you appreciate there's a difference in both of these tumors. This is low grade. Each one of these round structures is a cell. Every cell there looks like one another. It's a low grade tumor. This is what a biologically aggressive tumor looks like. Many tumor cells, some elongate, some round, some big, some small, all with very dark aspects to the cell. Grade 3, potentially this would be grade 1. Difference in morphology, difference in biology. Again, this relates to grade with regards to the probability of developing metastases, which determines the type of treatment. These are names of some of the low-grade sarcomas. This is an example of a high-grade sarcoma to make the analogy more understandable. Remember, I said that sarcomas recapitulate their normal tissue counterpart. In this example, the normal tissue counterpart is a picture of Elvis. This is a low-grade sarcoma. Yeah, it's making fat. I can identify that. Probably low risk or close to zero risk of metastasis. This is a high-grade sarcoma. Very difficult to identify its normal tissue counterpart. This is the biologically aggressive type of sarcoma, and these are just examples of a sarcoma that makes bone low grade and high grade. And again, you can appreciate at least there are changes that are noticeable between those different grades. Because again, the grade is related to risk of metastasis. Patients who die of sarcoma unfortunately die from metastatic disease within the lung, and this represents a lung tissue, with a lot of metastases. I just want to briefly give you information about what happens to a sarcoma when a surgeon removes it. I can tell you at University of Miami, the surgeon is next floor down in the operating room. They do their excision, they remove the sarcoma, and I'm right next to them and they give it to me. I receive the sarcoma. I take it up into the laboratory. I cut the sarcoma. My goal is to identify the sarcoma is there and the relationship of the sarcoma to where the surgeon made their cuts. Because I want to help the surgeon to be certain that he or she removed all of the sarcoma. And the way we do that in the laboratory, this is a piece of muscle, a segment of muscle within which is a patient's sarcoma. We actually paint it with ink, India ink. Why? Because it attaches to the tissue. It is not removed while we process that tissue to generate slides. So after I paint it, and wherever there is black, that is where the surgeon cut. So I mark where the surgeon has been. I cut it with a knife very carefully, like a loaf of bread, while the patient is on the operating room table to say, this is where the closest margin is. Maybe you should consider taking additional tissue. Or tumors far away from all margins, everything, I don't know why. This is what it looks like under the microscope. Here is the sarcoma. You can see for those up close, there's ink here and the color is blue. I actually measure it. And it might be a millimeter. It might be less. Now the goal with regards to removing sarcoma is to have a margin, even though it may be very thin, of no sarcoma. And that's the goal. And that is called a negative margin, and that's what this is. The other thing we do in the laboratory, say a patient has a sarcoma, a biopsy, it's a sarcoma, and the sarcoma team recommends we want you to have chemotherapy before any surgery. And the rationale behind that is multifold. Maybe that chemotherapy is going to make the sarcoma smaller as the chemotherapy is effective, kills the cells so it shrinks in size, and it's easier to remove. Maybe giving that chemotherapy is going to affect the cells, and the medical oncologists want to know whether that cocktail of drugs or targeted therapy, is it effective or not? And the best way to do that, sarcoma, treat it, remove it, and then have the pathologist look at all aspects of the sarcoma to determine how much of that sarcoma is still alive and how much is dead. And the greater percentage of that sarcoma is dead, the greater the likelihood that type of medical therapy is going to be successful. Because if it's killing the sarcoma in my distal femur, then it's probably killing any sarcoma cells within my lungs. Currently, the minimum number of percent necrosis that we think reflects a lot of sensitivity of the cancer cells, the sarcoma cells, to the drugs is at least 90%. And that's a lot. We even like to see it at 100% if possible. So, what should the patient know about their disease, sarcoma? They should know what kind of sarcoma it is. They should know the grade of the tumor. They should know if it's resected, or what are the margins like? Is there evidence that the sarcoma is in the blood vessels around the tumor? All of that is extremely important. And again, the patient needs to push and ask a lot of questions so that they're offered the best treatment possible. So, a lot of people in taking care of patients with sarcoma, have done a tremendous amount of hard work, long hours every day. Whatever I know, I'm standing on the shoulders of somebody else. As we make more advances in understanding the biology, diagnosis, and treat sarcoma, we need a really smart group of creative people who are thinking out of the box, so we stop what we've always been doing in the past. Because, yeah, we've done a good job, but we can do better. And that's where we're always pushing to do better for more people. And requires a really coordinated effort by the patients, by their support groups, the physicians, and really as a society to provide the resources so we can make advances in treating this disease. Thank you very much.
Thank you so much.
Oh, yeah.
Will you be around, Dr. Rosenberg, for questions later? We're gonna go into a break, yeah. Okay, great. So I'm sure I'm not alone. Those were brilliant presentations by Dr. D'Amato and Dr. Rosenberg. Awesome. Thank you. We are going to go into a short break, 10 minutes, stretch, go grab a drink of water, bathroom break, and then come back in here. And then we're going to hear from Dr. Jonathan Trent. Dr. Rosenberg and Dr. D'Amato will be up here for just a few minutes for questions if you have them. Thanks.
Wow. I'm like, I may shove it over.
Anyways, all right. Next, last year we were like way behind in the schedule, and of course it's happening again. So that's why I have to put my foot down. Okay. So I am just very thrilled to introduce our next speaker, Dr. Trent, MD, PhD, which is like medical school and then a PhD. So he's a doctor. Which is a lot of school, okay? And we stole him from MD Anderson. He was my mentor, actually, for many years, and he's just has a world of knowledge about sarcoma, has been involved in a lot of research because of the PhD portion of his MD doctor. And he's built a fabulous sarcoma program here in Miami. And not only is he just a fabulous doctor, but he's a fabulous person in general. He's from Oklahoma, which I never met anybody from Oklahoma before. Super nice people, okay? And he has 5 kids. Which I can't even fathom because I had a fish once, that's all. And so, and I met the whole family, and we like to play cards and pass the pigs, which if you've never played pass the pigs, I highly recommend. Anyways, but warm welcome to Dr. Trent. Thank you so much.
That was certainly the most unique introduction.
Oh, sorry, Dr. Trent.
Dr. D'Amato. And so welcome everybody. How great has this been? This has been really an amazing event. Thank you, Sarcoma Alliance, Alyssa, everybody that's worked to put this event together. It's amazing. These types of events really impact the field, they impact patients. I always learn something when I'm at a patient education conference because we all work in our areas. Yes, I'm in sarcoma, but I'm medical oncologist like Dr. D'Amato. Dr. Rosenberg is a pathologist, so we always learn something from each other. And what I'm going to talk about today is an area that is really brought together years and years of research in the laboratory, understanding the molecular causes of cancer, and combined that with all the new pharmaceutical discoveries that can now target some of these genetic mutations for patients in the clinic. Now these don't apply to everybody, but certain types of sarcoma do have certain targetable mutations that I'll show you in a little bit. So this is the spectrum of the common sarcomas that we have in clinic. Some of you may have something that's not on this list. This is not the complete list. The complete list is over 200 different unique types of cancer. Each one of these is different. Sarcomas are different, you've heard today, than the common types of cancer called carcinomas. There's over 200,000 women diagnosed with breast carcinoma each year. Sarcomas are different. These are cancers of the mesenchymal tissues, as Dr. D'Amato and Dr. Rosenberg explained. But these are also, sarcomas are often caused by unique genetic events, mutations in the DNA that alter a protein in a normal cell, and it turns that normal cell into a cancer cell. And this is a list of some of these. This is not an exhaustive list, just an example of different types of genetic events. And so one gene being able to turn a normal cell into a cancer cell is unique. Carcinomas often don't do this. It's usually multiple mutations over time. So it's much harder to use targeted therapies in precision oncology on carcinomas, but we've had really some great success in sarcomas with this approach. Now, these are some of the therapies, systemic therapies that go throughout the body that medical oncologists use to treat our patients. On the left are really the common chemotherapies that we use for different types of sarcomas, and each sarcoma on that list is different in what type of treatment we use. So we have over 50 different sarcomas. We have on this page over 20 different medical therapies. And as a medical oncologist, it takes years and years of experience to be able to really understand the disease and pair it with the appropriate therapy. And that, the first foundation, the critical part of that is a pathologist like Dr. Rosenberg being able to make the right diagnosis. Once we have the diagnosis and we understand the genetics of the tumor, then we can develop the optimal treatment on the patient. On the right side are some of the targeted therapies that you can see that target specific proteins that are on the tumor cell and less so on normal cells. So we'll be talking about precision sarcoma. So what is precision oncology, precision medicine, precision sarcoma? Well, when somebody goes to the doctor and gets eyeglasses, not everybody wears the same size eyeglasses. Your doctor does an examination and develops eyeglasses specifically for you based on your vision. Well, that's the whole concept of precision oncology or precision sarcoma. And that's the ability to do testing on the DNA of a patient's tumor in order to identify what is the gene that's mutated that turns the normal cell into the cancer cell. Because if it's one gene, that's kind of like an Achilles heel, something that we can target with a therapy. And this type of testing is called next generation sequencing or mutation analysis, it might be called. There's several names for it. We often refer to it as NGS. The other type of testing that we're doing increasingly in our clinic at Sylvester is circulating tumor DNA. As cancer in somebody's body, as a normal process and normal turnover releases DNA that makes its way out to the blood, and we can now test that DNA level and even mutations in the DNA on a blood test in certain select situations. We also can use this information, whether it's next-gen sequencing or circulating tumor DNA, to help make a diagnosis at certain times, because there are certain types of sarcomas that have a specific mutation or translocation or deletion that is at times highly specific for that sarcoma. This type of testing will never replace a pathologist, but it can help with challenging and difficult cases and confirmed diagnoses. And then last, we're going to talk a little bit about treatment. If a patient's tumor is being driven by a mutation that has turned that normal cell into a cancer cell, what if we target that mutation? And what if we can turn it off, just like turning off a light switch? Well, it's been highly effective in several types of sarcomas. And again, not every type of sarcoma, but we're slowly chipping away and increasing our ability to use targeted therapy for sarcoma patients. So here's the way we approach targeted therapy, precision medicine at Sylvester. So it really takes place at the foundation of being able to perform the testing. We order it in our clinic just like ordering a CBC or a chemistry lab test. We get the results. We use some complicated software algorithms to understand all of that data in the DNA. And then after that process, we end up with a mutation in a patient's tumor. We have to determine, is that mutation important for the cancer? And then lastly, through our molecular tumor boards and other approaches, then we identify whether there is a therapy or a treatment that can be assigned to that patient or delivered to that patient in a way that makes a lot of sense and could be effective. And lastly, we develop strategic alliances with a number of different other cancer centers, large cancer centers throughout the country through our Precision Oncology Alliance, where we actually share this data and can share outcomes in order to figure out how much we're helping patients. And so once we get the data, if there is a mutation and there is a medication, then we try our best to get that medication to the patient. That may be possible through a clinical trial. We have clinical trials at Sylvester, such as one from ASCO called TAPER, one from the National Cancer Institute called MATCH. And these clinical trials really allow us to have about 40 to 50 different medications that might be options for sarcoma patients. We also have internal testing clinical trial called DEPICT. We have circulating tumor DNA testing available through GRAIL for our patients. If we don't find a mutation, which also happens, there are several sarcoma types that usually don't have these mutations predictably in their DNA, then we may look at other approaches such as non-targeted therapy or immunotherapy is increasingly becoming an option for sarcoma patients. So I'll start by talking a little bit about GI stromal tumor. I know there's a few patients here with GIST. GIST is one of the more common types of sarcoma. GIST is the most common sarcoma in the GI tract. It affects, some say, maybe as many as 5,000 patients per year in the US. That's somewhat disputable, but it probably represents about a quarter of sarcoma patients. These can occur anywhere in the GI tract, so a patient may present with different symptoms based on that. GIST is one of those cancers until targeted therapy really had no treatment for patients. Chemotherapy didn't do anything for patients with GIST. And so now I'm going to go back to targeted therapy, precision medicine. So GIST is one of the sarcomas that's caused by a mutation in the DNA. The mutations usually take place in this gene called KIT, K-I-T, and the mutations often occur in regions called exon 9 or exon 11. So even the regions where the mutation take place are increasingly becoming important. So what does KIT do? KIT's a protein on the surface of the cell. It's on a normal cell. When that normal cell gets a mutation, it turns that cell into a GIST. That protein then sends a signal to the nucleus and tells that tumor cell to do bad things like proliferate, survive, invade, metastasize. And this is all coming downstream from a mutated KIT gene. Well, Novartis, many years ago, developed this drug, imatinib. And imatinib binds to the KIT protein and turns it off, just like turning off a light switch. And when KIT is turned off, then the protein no longer sends that signal to the nucleus, and it shuts the tumor cell down and kills tumor cells and stops them from growing also. So now through our molecular testing called NGS, next generation sequencing, and circulating tumor DNA, now we understand that KIT mutated GIST is just one type. Now we know that there's a bunch of different types of this GIST. So we know GIST is a type of sarcoma, but increasingly we're learning that each sarcoma, each individual sarcoma, there are subtypes within that sarcoma. And some of these are molecular. In this situation, GIST can be caused by mutations in any of these genes shown here. So here's an example of a GIST on the purple arrow that actually got larger on imatinib. Well, we did next generation sequencing, and we found that this patient didn't have that usual KIT mutation, but had a PDGF receptor mutation. What that means is that there's a medicine that will probably be approved very soon by the FDA for GIST patients with PDGFR mutant GIST called avapritinib. And it's exceptionally effective at killing GIST cells with this mutation specifically. Here's another example of a GIST in the yellow arrow that got smaller on a medicine called vemurafenib, which is a RAF inhibitor. These medicines are used for colon cancer, they're used for different types of cancer. Well, every now and then there's a sarcoma patient with GIST who may have a mutation in this gene. So you have to know, you have to do NGS we do it on all of our GIST patients. Because if the regular medicine, imatinib, is not gonna work here. Vemurafenib worked really well. Later, we found there are mutations. When patients' tumors become resistant to these targeted therapies like imatinib, resistance emerges, and it basically takes two flavors. One's called exon 13 and one's called exon 17. Exon just means region in the DNA. So although all of the patients, most of the patients initially, when they're first diagnosed, are found to have these mutations in these exon 9 and 11 areas, over time, new tumors arise that have these mutations, 13 and 17 mostly, and these mutations have been found to be resistant to the initial therapy but sensitive to different therapies. So now we're even using targeted therapy approaches, next generation sequencing in resistant situations. So now for GIST patients, which is a type of sarcoma, we're really subtyping and picking therapies based on the genetics of an individual patient's tumor. So let's talk about some other types of sarcomas. So this is a type of sarcoma called dermatofibrosarcoma protuberans. We call it DFSP. And when we do next-gen sequencing on patients with this sarcoma, we find a translocation between a gene called collagen and a gene called PDGF. That translocation in the DNA, again, turns the normal cell into the cancer cell, and the cancer cell grows. This patient of mine had the DFSP right over the eyelid and was recommended to have his eye removed. And that was not an option to him, so we tried imatinib in this situation, which is a PDGF receptor inhibitor. It regressed away from the eyelid, and he was able to have eye-sparing surgery and is doing great today. Here's another example, and this is a type of sarcoma called pigmented villonodular synovitis, or the pathologists like Dr. Rosenberg have recently changed the name to tenosynovial giant cell tumor of the tendon sheath. Say that 5 times fast. And so we call it TCGT. And so anyway, this tumor is caused again by a translocation between collagen promoter and a gene, in this case, called colony stimulating factor 1 receptor, CSF receptor. And again, this translocation turns a switch on in the normal cell such that it acts like a tumor cell and grows without control. And this growth is driven by CSF1 receptor because it's overexpressed in the tumor cells. Well, now there are medications. We did these clinical trials at Sylvester, and now this medicine called pexidartinib is now approved. It's FDA approved for the use of TCGCT, PVNS, and it binds to this receptor, CSF1 receptor, and again, turns it off, just like turning off a light switch, and the tumors regress. Here's an example by the yellow arrow. This patient had this PVNS, TCGT, in a bad location, right in the brachial plexus. The surgery had been a bad surgery, but we were able to use this medicine to control and shrink the tumor. Well, there's another one called rank ligand and rank that leads to another event where there is proliferation of tumor. In this case, the tumor is called giant cell tumor of bone. And these can be treated with a medicine called denosumab that's an antibody that binds to the ligand and pulls it away from the receptor and is highly effective also. This patient had a PET scan. You see on this PET scan, black is tumor, goes away after only a few months of treatment. When I first saw this patient, she was on a lot of morphine. She was having difficulty walking. Within 2 weeks, she was wearing high heels and salsa dancing in Coral Gables. Recently, there's been another medicine approved, couple actually, larotrectinib and entrectinib, and these bind to a protein called TREC. It's another receptor, can be turned off just like a light switch. These can show up in a number of different sarcomas, such as leiomyosarcoma, GI stromal tumor, congenital fibrosarcoma, infantile fibrosarcoma, number of different types. But the bottom line again is that these large tumors can regress on therapy because the therapy binds to TREC, specifically mutated TREC, and can kill tumor cells. Dr. D'Amato's favorite protein to attack is PI3 kinase, mTOR, and this is an example of a patient with a myxoid round cell liposarcoma whose tumor got smaller from left to right on an mTOR inhibitor. Recently, Dr. Rosenberg played a critical role in identifying a mutation in a protein called IDH, isocitrate dehydrogenase. We did the first trial here at Sylvester, first in human trial, treating these patients with a mutant IDH inhibitor, and this is specifically for patients with chondrosarcoma. It also works in other types of cancer like glioblastoma, cholangiocarcinoma, some leukemias, but it's also effective in chondrosarcoma. So this is a bone tumor that you heard about earlier. And anyway, the IDH, again, turns the mutation in this protein turns the normal cell into the cancer cell. And there are mutant IDH inhibitors that bind to the mutant protein, not the normal protein. It's so specific they bind to the mutant protein and can shut it down. This is an example. What you see in white here is, you can see all of this white, which is sarcoma. It almost all goes away after treatment on this drug. And the patient has been on this medicine now for almost 5 years with really no side effects. So immunotherapy is also a targeted therapy. Immunotherapy is the whole concept that when somebody has a cancer, that cancer cell is evading the immune system. So using targeted therapy, we can target the proteins on the immune cells, but also the proteins on the cancer cell that the cancer cell is using to evade the immune system. So cancer cells live in a patient's body with a camouflage on that the immune system can't see. Now we have medicines at our disposal that can remove that camouflage. And this is just a cartoon showing a tumor cell, a normal cell, how it stays away from the immune system. Our body doesn't attack normal cells. Well, the cancer cells use the same approach to try to evade the immune system. The important cells that kill tumor cells are called T cells. And then there's another cell called a dendritic cell that presents and shows the T cell what to attack. At Sylvester, we just recently completed a dendritic cell vaccine protocol where we try to use a patient's own tumor to educate the immune system and train the immune system to attack the tumor cells. And there's another trial using two targeted therapies, a medicine called axitinib, which binds to PDGF receptor, KIT, a number of other different receptors in the blood system of the tumor to attack the tumor in that way, and at the same time simultaneously removing the immunosuppression, the camouflage from the tumor cell, using a medicine called pembrolizumab. This trial finished at Sylvester about 6 months ago, maybe, and there's still one patient still receiving those medicines. So I'd just like to conclude that there's a lot really going on right now in the sarcoma world about targeted therapy, precision medicine, and immunotherapy. We've had some great breakthroughs in certain sarcoma subtypes like angiosarcoma, alveolar soft part sarcoma with immunotherapy. We still have a long way to go to find immunotherapy for the larger proportion of sarcoma patients for which we don't have effective immunotherapy yet. But But research and clinical trials such as these give us hope that we will continue to chip away, make breakthroughs, and really develop therapeutic approaches such as targeted therapy and immunotherapy that are not like the chemotherapy that causes all of the severe side effects, but work in a smarter way to eradicate sarcoma cells in patients' bodies. And so with that, I'd just like to really end by thanking Dr. D'Amato, who helped organize the meeting, thank the rest of the sarcoma team back at Sylvester, who really worked day in and day out to advance sarcoma patient care, and also plug our to-be-announced position that's open. We're looking for another medical oncologist. Anybody know somebody looking to live in warm, sunny Miami? I'd be happy to answer any questions.
Thank you, Dr. Trent. Dr. Trent will be around to answer some questions, but right now, I don't know about you, but I'm feeling a little hungry. So we have lunch right outside these doors. So grab the box lunch, come back inside, and then we'll start our Back by Popular Demand, the nonprofit resources portion of the agenda. Thank you.
I already signed. I like it. I want to do, I mean, you think
Yeah, we're doing live Facebook.